There's a pill sitting on millions of kitchen counters right now. It gets taken every morning without a second thought. The doctor prescribed it. The blood pressure numbers came down. The chart says controlled. And so the assumption is that everything is fine. But inside the kidneys of the people taking that pill, something has been quietly shifting for years. Not dramatically, not painfully, just slowly in the background, without a single symptom to raise an alarm. And the tragedy is not that the pill is dangerous on its own. The tragedy is what happens when nobody watches. This is about lisinopril. And before you assume this does not apply to you, stay with me. Because what I am about to walk you through is not a scare story. It is a monitoring story. And the difference between those two things could be the difference between catching something early and finding out when it is already too late to reverse. Let me start with a woman I will call Dorothy. Dorothy is 73 years old. She had been on lisinopril for just over 9 years when she came across the information I am about to share with you. 20 milligrams every morning. Her blood pressure was beautifully controlled. Her doctor was satisfied. On paper, Dorothy was doing well. But Dorothy had a dry, scraping cough that had been with her for nearly 5 years. She had ankle swelling that crept in every afternoon like clockwork. She was exhausted by early afternoon in a way that sleep never seemed to fix. She brought all 3 of these things up at her appointments. She was told the cough was a known nuisance with that class of medication. The fatigue was her age. The swelling was too much salt in her diet. She cut the salt. The swelling stayed. Dorothy kept taking the pill because she trusted the system. And in many ways, the system was not wrong to prescribe it. Lisinopril is a genuinely useful medication. But what the system failed to do was keep watching after the prescription was written. And that is where everything began to quietly unravel. Here is what lisinopril actually does inside the kidney, because this is the part that most patients are never told. Your kidneys contain millions of tiny filtering units. Each one has 2 small blood vessels, one that carries blood in and one that carries blood out. The filter cleans the blood in the space between those 2 vessels. Lisinopril works by widening the vessel that carries blood out of the filter. When that vessel opens wider, the pressure inside the filter drops. Lower pressure means less mechanical stress on the delicate walls of those filters over time. That is the protective effect your doctor was referring to when the pill was prescribed. And it is real. But here's the part that follows immediately after, the part nobody explains. When that outgoing vessel widens, the filter becomes less efficient. It processes less blood per minute. The kidneys slow their cleaning rate. A waste marker in the blood called creatinine begins to climb. A modest rise of 10 to 25% is considered acceptable and expected. That is the pill doing exactly what it was designed to do. But if nobody measures that number after the prescription is written, nobody knows whether the rise stayed in the acceptable range or kept climbing past it. Guidelines for patients on lisinopril call for kidney function testing within a month of starting the medication, and then every 3 to 6 months after that. Every 3 to 6 months. That is the standard. Now think honestly about your own experience. When was the last time your doctor ordered a kidney blood panel specifically because of your lisinopril? For the majority of people who have been on this pill for years, the answer is that they cannot remember. Or the answer is that it only happened once at the very beginning. The prescription gets written, the blood pressure responds, the chart is updated, and the follow-up visits focus on the number on the cuff. Nobody circles back to the kidneys unless something goes obviously wrong. And the problem is that things can go quietly wrong for a very long time before they become obvious. Dorothy's creatinine, when it was finally checked after years without measurement, had climbed 40% from where it started. The threshold where doctors begin to take serious notice is 25%. She had been sitting above that threshold for an unknown period of time, while her chart said everything was fine because nobody had looked. Now here is what makes this more urgent. The creatinine is not the only thing that lisinopril changes in the blood. The medication also affects potassium. Lisinopril works partly by reducing how much potassium the kidneys flush out. In controlled amounts, this is harmless. But potassium is not a mineral your heart can afford to have in excess. When potassium climbs above normal range, It begins to interfere with the electrical signals that coordinate each heartbeat. The disruption can start subtly. At higher levels, it can produce dangerous rhythm abnormalities. At the extreme end, it can stop the heart. The frightening part about elevated potassium is that it produces no reliable warning symptoms at levels that are already medically serious. A person can feel completely normal while their potassium is sitting at a number that makes an emergency physician move quickly. You cannot feel it rising. There's no pain, no obvious signal. And if nobody is measuring it, nobody knows. Dorothy's potassium, when checked, was sitting at the very upper edge of the acceptable range. One significant stressor on her system, one bad illness, one day of poor fluid intake, and it would have crossed into territory that carries real cardiac risk. She had no idea. Her doctor had not flagged it. The pill she trusted was quietly stacking a risk that no one had mentioned to her. But neither the creatinine nor the potassium is the most immediately dangerous thing I need to tell you about. That distinction belongs to a combination of medications that has a name in clinical circles. It is called the triple whammy, and it is not rare. Based on everything observed in patients on lisinopril, more than a third of them are taking this combination without any awareness that it is dangerous. Here is what it involves. Lisinopril plus a diuretic, the water pill many people take alongside it for blood pressure or swelling, plus a common over-the-counter anti-inflammatory painkiller. Ibuprofen, Advil, Nurofen, whatever name it goes by in your country. The kind of pill people reach for without a second thought when knee aches, a back stiffens, or a headache settles in. Each of these three medications affects the kidneys through a different pathway. Lisinopril widens the outgoing vessel of the kidney filter. The diuretic reduces the total volume of fluid in the bloodstream, which means less blood arriving at the kidneys to be cleaned. And ibuprofen blocks a specific protective chemical inside the kidney that kicks in during times of low blood flow to keep the filters running. When blood flow drops, that chemical normally constricts the incoming vessel slightly to maintain pressure in the filter. Ibuprofen shuts that mechanism down. When all three are present at the same time, the kidney filter is getting hit from three directions simultaneously. The incoming blood volume is reduced. The protective mechanism is disabled, and the outgoing vessel is already artificially widened. Pressure inside, the filter collapses. In the worst scenarios, the filter stops working entirely. This is acute kidney injury. It can develop within 48 hours, and it can be severe enough to require hospitalization. Research published recently confirmed that this combination doubles the risk of sudden kidney failure. Doubles it. And yet not one of the three medications carries a warning on its label about the others. The lisinopril bottle says nothing about ibuprofen. The diuretic says nothing about the combination. And the ibuprofen packaging says nothing about the particular danger it poses to someone already on the other two. Nobody connects them because in the medical record, they live in different categories. Blood pressure medications over here. Pain relief over there. The system does not open all the drawers at once. But your kidneys live in one body, and they receive the consequences of everything at the same time. Dorothy had been taking ibuprofen twice a week for chronic hip discomfort. Lisinopril every morning. Diuretic every morning. The triple whammy, for years, unrecognized by anyone who reviewed her chart. There is a related danger that comes from a different direction entirely, and it is one that catches people off guard because it does not involve any medication error. It involves something as ordinary as a stomach virus. When lisinopril and a diuretic are both present in the system, the kidneys are already working with a tighter margin than normal. If a person becomes significantly dehydrated from vomiting, from severe diarrhea, from any illness that prevents adequate fluid intake, the blood volume could drop sharply. Less fluid means less blood reaching the kidney filters. And when there is already a medication widening one vessel and another medication that has been reducing fluid levels, the kidneys can be pushed into a crisis state within 24 to 48 hours. Standard guidance says that patients on lisinopril and a diuretic should be instructed to pause both medications temporarily during acute illness involving dehydration and to seek advice about fluid replacement. Most patients on these medications have never received that instruction. Dorothy had not. She had taken her pills faithfully through illnesses because she was conscientious, because nobody told her to do otherwise. And each time, her kidneys absorbed another stress that could have been avoided with a single conversation that never happened. Now about that cough. Up to 15% of people on lisinopril develop a dry, persistent cough that does not respond to cough medicines, does not go away with allergy treatment, and baffles multiple physicians who do not connect it to the blood pressure medication. The mechanism is well understood. Lisinopril works by blocking an enzyme that normally breaks down a particular chemical in the airways. When that breakdown is blocked, the chemical accumulates. In susceptible individuals, the accumulation triggers a persistent cough reflex. The cough can appear weeks after starting the medication. It can appear months later. It can appear years in, which is precisely why so many physicians and patients fail to make the connection. Dorothy's cough had lasted 5 years and had earned her 2 misdiagnoses, allergies from one doctor and acid reflux from another, before anyone ever suggested it might be connected to a pill she had been taking since long before the cough started. There's an entire class of blood pressure medication that works through a closely related mechanism, protects the kidneys in the same way, controls blood pressure comparably, and does not cause the cough. Switching from lisinopril to a medication in that class is straightforward. The cough typically resolves within days to a week. Dorothy's cough was gone in 5 days after the switch. 5 years of daily coughing, resolved in less than a week, once someone simply made the connection. The final piece of this picture involves magnesium, and it is the piece that ties the other dangers together in a loop that can spin for years without anyone recognizing it as a loop. Lisinopril by itself does not significantly deplete magnesium, but the diuretic that many lisinopril users also take does. Diuretics increase urinary output, and magnesium is flushed out along with the excess fluid. Magnesium is essential to the function of smooth muscle tissue, including the smooth muscle that lines blood vessel walls. When magnesium is consistently depleted, blood vessel walls become less able to relax. They stiffen. Blood pressure becomes harder to control. When the blood pressure climbs despite medication, the physician sees a higher number and increases the lisinopril dose. The higher dose increases the load on the kidney filters. The diuretic continues depleting magnesium. The vessel walls continue stiffening. The pressure continues rising. The dose continues increasing. And the kidneys sit at the center of this loop, absorbing more strain with each cycle. Dorothy had been inside this loop for the better part of a decade. The magnesium depletion was never measured. The connection between the diuretic, the magnesium, the stiffening vessels, the climbing pressure, and the escalating lisinopril dose was never identified as a single connected system. It was treated as blood pressure that needed more medication, which made everything worse. When Dorothy finally brought a complete picture of her laboratory results to her physician, the creatinine elevation, the borderline potassium, the evidence of the triple whammy combination, the cough, her doctor did not dismiss her. He listened. He made changes. The lisinopril was replaced with a medication from the related class that does not cause coughing. The ibuprofen was discontinued, and a kidney-safer alternative for her hip pain was identified. The diuretic dose was adjusted. Blood work was scheduled every 3 months going forward. 8 weeks later, Dorothy's creatinine had dropped. Her potassium had normalized. The cough was gone, and her physician, reviewing 2 years of blood test records in which her kidney numbers had been drifting in the wrong direction without a single test to catch it, told her directly that the oversight should not have happened. Dorothy told him she was not angry at him personally. She understood that he was working within a system that prioritized managing the blood pressure number over monitoring the downstream effects of the medication used to manage it. The system trained him to prescribe, confirm the response, and move to the next patient. It did not build in a mechanism to circle back to the kidneys every 3 to 6 months the way the guidelines actually require. That gap between what the guidelines say should happen and what actually happens in most practices is where kidney damage hides. It hides quietly, without symptoms, for months or years in the space between a prescription that was written and a follow-up that was never done. What you can do right now is straightforward. Ask your doctor for a kidney function blood test. Ask specifically for creatinine and potassium. Ask when those numbers were last measured and what they showed. If you take a diuretic alongside lisinopril and you use ibuprofen or any similar anti-inflammatory for pain, tell your doctor and ask whether that combination is safe for you specifically. Ask whether there is a cough-free alternative if the dry cough has been affecting your quality of life. Ask what you should do if you become sick with vomiting or diarrhea. Ask for blood work every 3 months. These are not aggressive questions. They are not accusations. They are the conversations that the guidelines already say should be happening. You're not asking your doctor to do something unusual. You are asking for what the standard of care already calls for. Do not stop taking lisinopril without medical guidance. Do not change your dose or skip your medication on your own. But do ask the questions. Because Dorothy's story did not have to involve 9 years of unchecked kidney decline, 5 years of an undiagnosed cough, and years of a dangerous 3-drug combination that nobody flagged. It could have been caught at year 1 with a blood test that takes 24 hours to result and costs almost nothing. One conversation with your doctor. One blood panel. That is the distance between catching it early and finding out when it is already far along. Your kidneys have been quietly doing their job. The least the system can do is quietly check that they still can.